I do believe in a balance for sure, and you often find people who get so restrictive, and it just starts to affect their mental health because they can't go out, they
Yeah.
can't go. So it is that balance. And I remember a patient who had colitis, and on a strict diet, went to Italy, had a holiday, was eating pizza, pasta, everything, and they were fine. So
Yeah.
so many factors,
Yeah.
and again, we can digress into the wheat in Italy is different from the wheat here. It's all sorts of things like that, but I do believe in balance for
I
the long
think
term.
there's a mindset element as well. I've got a friend of mine who's definitely lactose intolerant, and he went to America. He went to like Disneyland, something like that, and it's like favorite place in the world. Stress free, loving life. Had all the cheese he wanted. Didn't have any symptoms. He was like, it can't be the quality of the dairy that I was eating. I was eating like the worst type of dairy. His mindset, it was his mindset. Like when he's back here in the UK, like he's running a company, super stressed and all that kind of stuff. So I think there's a rich interplay between our perception and our gut, as well as we know through the gut-brain axis. So I think that's really important.
Yeah.
Doctor's Kitchen. Recipes, health, lifestyle.
Quick fire questions, if you like. Coffee or tea?
Tea.
Tray bake or stew?
Tray bake.
Carrots or kale?
Carrots.
Steak or fish? Or neither?
I'm vegetarian.
Okay.
Definitely not steak.
Definitely not a steak then. Yeah. Okay. Fine. Let's I want to start by talking a bit about like how you got into because we've known each other for a little while now through Ian and just me living. Actually, when was it? Did we meet at one of Fiona Tucker's events or something? Was that the first time?
We did a talk. Yeah, so we did a talk. There were a few guest speakers, including Fiona, and I think she'd invited you as well. So I think that was up in it was in Sydney, and I did a little talk on gut and thyroid. So
that's amazing because this is when I was like getting into the whole sort of social media side of things, and I was very new to it, and I was working in Mona Vale, and this event was like up in the Northern Beaches somewhere.
Avalon.
And I came along. It was like a whole new world for me. I think it must have been like 2014, 2015, something like that. Years and years ago now. So tell me a bit about how you got into it. Like, what was the impetus?
Yeah. So I guess if I go back to my time in London, like I studied in London, I did my medical qualification in London, worked as a GP there for several years. I was drawn to general practice because I liked all the specialties. I actually couldn't make my mind up on what I wanted to do, but I loved the concept of general practice and that continuity of care and seeing the whole family and everything and just encompassing all the specialties. And I went straight from my registrar year into a partnership, and I was working in an inner city practice, very busy, a lot of complex cases, ethnic minorities, and it was, as NHS GP jobs are, very stressful, 10-minute appointments, and it started to take its toll. I recognized that I was interested in a lot of other things. So even back then, I started to do a little courses that I just saw around. Like I did a CBT course. I found a medical acupuncture course. So I started just delving into little things I was interested in, and I also found, interestingly, the masters in Guildford for nutrition. But at that stage, I actually wasn't ready to embark upon a master's or leave my job or anything like that. But I did my own reading and research and everything. And but as the years passed, it got to that point where I thought it was just getting quite stressful, frustrating, feeling quite burnt out. And I always had an interest to travel and work abroad. And around that time, so many of my friends were going to Australia, New Zealand, just doing 6 months a year. And I thought, well, it would just be great just to get a holiday and also just experience what medicine's like elsewhere. Like, is it just the UK? Is it just the NHS? Is it just, So I actually went to New Zealand first for a year. I did an A&E job there. And then I had passed Sydney on the way to New Zealand. And I thought, I I just fell in love with Sydney. I thought I'm coming back here.
Mm.
So I got a job in Sydney as a normal GP, and it was actually
A
during that
normal
first
GP, quote unquote. I
a
love
normal GP.
that.
And it was a standard GP job. And it was during that time I saw a flyer in one of the GP magazines, and it was for a nutrition in medicine conference organized by ACNAM, which is the Australasian College of Nutritional and Environmental Medicine. And I thought,
Mhm.
wow, this just sounds like, a pathway here. And I went away, I went along to the conference. It was just for the weekend, and I just spoke to lots of other delegates there, and some of them were embarking upon some other training organized by ACNAM,
Mm.
and they had a fellowship program where you can just sort of do various modules and all the different specialties like pediatrics, women's health, metabolic disease, etc. And I just loved the conference, and I just loved what I heard from fellow delegates, and I thought this is definitely a path for me. And so I took myself down that path. I started doing, module after module, and the thyroid adrenal module was very interesting. Um, I was learning things that I'm thinking, did I miss that lecture at medical school? Like, why haven't I heard about selenium and zinc and reverse T3 and how so much is involved in the thyroid? It's not just about the thyroid. And I also, around that time, started in a holistic clinic. So up in the northern beaches as well in Narrabeen, and started seeing a lot of patients there, across the whole variety of different conditions, but saw a lot of women mainly with a lot of thyroid symptoms, and also symptoms where there was just no diagnosis. And
Mm.
I was getting so many patients like that, and coupled with the learning I was doing through ACNAM, and also later on the Australasian Society of Lifestyle Medicine and the Institute for Functional Medicine. So I came across all those later. I hadn't come across them before while it was in the UK. It was more, as you get to know people in this world, you sort of get to know this whole world sort of opens up. So I guess I started to get an understanding of what's actually going on here. So common scenarios would be, someone's been diagnosed as hyperthyroid or Hashimoto's, they're on thyroxine, but they're coming in, they're still not feeling well. There may have been
Mm.
some improvement with the medication, but they're still fatigued, they've still got brain fog, they're still not losing weight. I'm thinking, what's going on? But with that background of that extra knowledge I had now, I was able to sort of make some sense of that. And as well as obviously seeing people who didn't have any formal diagnosis and recognizing why that may be, that they're in a subclinical hyperthyroidism scenario, or the hormones are normal but the antibodies hadn't been tested. So it was quite enlightening. So yeah, my journey started there, and I guess Sydney for me has been a turning point in how I've practiced medicine. And from a time when I was thinking of giving up medicine when I was in London, I mean, you know, I love what I do now.
This might seem like an odd question, but along the arc of your career, which has spun over 20 years now, from being an inner city GP in the UK to going to New Zealand, getting involved in general practice in Australia, and now into a more holistic approach. How has your own health been affected? Have you sort of sought things along your educational journey that you've put into practice on a daily basis now that you've seen the results personally, or is this something really that was a reflection of the need that you saw within the community of patients that you were treating?
It was definitely both. Certainly for myself, I was feeling stressed and burnt out, and I knew something had to change. And now I can look back and think, how I had, all those sort of thyroid symptoms myself as well, and how I've been able to, with this new knowledge, improve my own life and lifestyle as well. So yeah, I would say it's a bit of both my own personal journey, in terms of
Mm.
finding something I love to do, um, and also just finding that purpose and feeling more aligned in myself as well, and also of course meeting the needs of patients who are largely unheard in conventional general practice, unfortunately.
Yeah, Yeah, and within that, when GPs go down this path of looking at nutritional medicine and integrative and functional, even sometimes I feel like my back gets up a bit, like, oh, my skepticism radar just like goes straight up. Is it the same in Australia? I mean, we were just talking before we started about how like we met, and I was in Australia with you, and we met at one of these talks. But it, is it more accepted in that part of the world, or is it just as sort of frowned upon?
I feel it is more accepted. I feel like integrative medicine here is busy. There are so many practitioners across all the major cities, especially in Sydney, Melbourne, Brisbane.
Mm.
So there's certainly a need where patients are seeking it and are more open to it, I think, as well. Um,
Mhm.
of course, there's still, there is still, in terms of conventional general practice and conventional specialists as well, I still have patients come back saying, you know, they saw their gastroenterologist or the endocrinologist and they asked about diet and they were told, no, diet's got nothing to do with it. And why are you off gluten? And, it's surprising that there is some ignorance still out there, but I would say
Mm.
overall people are more open to it, and I think it's more accessible because there certainly seem to be, I feel, more practitioners here as well across not just integrative medicine but also allied health as well.
Yeah, yeah. Maybe it's the access to water, fresh air, good
Yeah,
produce.
yeah,
Like, oh, Australia seems
yeah,
pretty good.
yeah, and yeah, lifestyle and like I said, the lifestyle here is fantastic, which is just been a big part of how my life has changed as well. So
Yeah, well, we're in the
yeah,
depths of winter right now, so I'm missing it massively. Like December is like ideal time to be in Sydney right now. But anyway, we're going to move swiftly on from that. You mentioned you recognize your own thyroid health symptoms. Would you mind going to a bit more detail about that? What did you notice within yourself?
Yeah, just not wanting to get up in the morning and pressing the snooze button, and
Mm.
thinking I've got some sleep, but not wanting to wake up, and go to work, and just the monotony of work and the stress when you get to work of just I guess, yeah, and also just feeling frustrated and helpless that you can't always help people, that you just giving out medication and then more medication to cover their side effects. So combination of things, but certainly low energy and just not feeling
Mhm.
fulfilled. Um, yeah, for sure.
Yeah, yeah. Okay. Well, look, we're going to talk a lot more about thyroid health in general today, but I think, just to take the listener on a journey with us without having to pull open a medical textbook and look up the abbreviations and jargon that we're going to unfortunately use at some points during the pod, why don't we give people sort of an overview idea of what thyroid health actually entails? Because I think, you know, as a person who isn't in medicine, they've probably heard things like Hashimoto's and Graves and subclinical
Mm,
hyperthyroidism and thyroid health in general. And it's a really, really
yeah,
confusing world because there are so many different ways in which you can describe thyroid health, quote unquote. So I wonder if you can give us sort of
yeah,
like a broad idea of what we mean by underactive, overactive, what the other terms and how those fit into those broad categories, and other sort of areas that you feel that we need to define before we dive deeper into the mainstream approach to thyroid health, and then the
yeah,
sort of, I don't want to say alternative, but the sort of nutritional and lifestyle approaches
yeah,
to thyroid health.
sure. So the thyroid gland is a small gland in the neck. It's butterfly shaped, weighs about an ounce, and for a tiny little gland, it does a lot. There are thyroid receptors everywhere in the body, and it controls so many functions. So, for example, it upregulates metabolism, neurotransmitters, is needed for protein metabolism, for growth development, is needed for gut function and intestinal motility, a wide range of functions, and hence a wide range of symptoms. Think of the thyroid gland as a thermostat. It's very sensitive to what's going on around it. or it's like a canary in the coal mine. And in fact, this word comes from thyros, which is a Greek word meaning shield. So there's links between the thyroid and every other part of the body. The most common scenario is hypothyroidism, and hypo is a general word meaning low. So it's low functioning thyroid, and that's the most common scenario that we see. So when we have hypothyroidism or underactive thyroid, there are various factors which we'll go into, whereby the thyroid function is slowing down. So imagine, just everything is slowing down. So the common symptoms that people would present with would be fatigue, it's low energy. So even if they may have had a good night's sleep, they're just tired on waking, or often have that dip around that 2-3 o'clock time, needing chocolate, coffee, etc. There can be brain fog, memory loss, forgetfulness, cognitive symptoms as well. There can be hair loss, which is obviously quite a disturbing symptom in women. And there can be weight issues as well. So that's also another common scenario whereby people aren't losing weight, or they're doing the right thing seemingly, they're exercising more, they've reduced their calories, they think they should be losing weight, but they're not. There may be gut symptoms, and often even constipation can be one of the only symptoms that someone may have, because the thyroid gland is so important for gut health as well. So there may be IBS type symptoms. There may be gut dysbiosis, which means an imbalance in the gut microbiome between the good and the bad bacteria. And there may be gynecological symptoms, so often heavy or painful periods. There could be fertility issues, recurrent miscarriages, and so forth. So because the thyroid gland is it's part of so many other functions, there can be wide-ranging symptoms. So like I said, it's much more common in women than men, so probably about a 10-to-1 ratio, but important to remember, because we often see men with those similar symptoms, but people don't think of thyroid when it comes to a male. But when we do the testing, and the relevant testing, you realize, oh, actually, you've got Hashimoto's, and hence the symptoms. So men can be forgotten. I think it's important to remember that as well.
Absolutely.
So hypothyroidism is the commonest thyroid disorder. So in Australia, it's said to affect about 1 in 30 people. And when we refer to Hashimoto's, this is autoimmune. Hashimoto's is the most common autoimmune condition. And the most common cause of hypothyroidism is Hashimoto's. But we have to remember, it's not just black and white. It's there's that whole shades of gray. So someone could start to develop a few antibodies. At that stage, they may be okay. They may just have subtle symptoms. When you do their thyroid testing, everything's totally fine. But if those insults to the body, to the thyroid gland continue, and that inflammation to the thyroid gland continues, then we'll start to see more symptoms. And in time, their thyroid hormone levels may be out of the range such that it's then picked up later. But again, the point here is, the earlier we can pick this up by doing the correct testing and interpreting the test correctly, and not just saying, oh, there's only a few antibodies, it doesn't matter. It does matter, because the studies have shown that when people have even low levels of antibodies or hormone levels that aren't optimal, over time, it can progress to over hyperthyroidism, which is where they really are underactive, and they likely will need medication. And the earlier
analogy,
we can intervene.
Sorry, I was just going to jump in there very quickly. The analogy I like to draw between that, just a few antibodies, that's fine. It's like, well, you're in the pre-diabetic range, so you don't have to worry about it too much. Just clean up your diet a little bit more. That's actually saying a lot. The fact that you're pushing your body up to that limit, because a lot of other things have had to happen along that journey of you becoming a little bit metabolic inflexible. I just wanted to punctuate that point.
And in Hashimoto's, the earlier that we can pick it up, it just means that there's going to be less disruption to the thyroid gland. Because often what we see clinically is that it may have been there for years, but people haven't had the right testing done. And as a result, they're at the stage where the thyroid gland has shrunk or atrophied so much that they do need external thyroid hormones. On the other hand, just to put things into perspective, we have hyperthyroidism, which is overactive thyroid. It's not as common. The autoimmune thyroid is called Graves' disease. So, and that's a speeding up of everything. So often there'll be weight loss, there'll be anxiety, palpitations. There can be some overlap. And in fact, even people with hypothyroidism or Hashimoto's can actually get flare-ups where there's this sudden release of thyroid hormone because of the destruction of the thyroid cells, and they actually temporarily have hyperthyroid symptoms. So it can get confusing, and that's where you need to do the adequate testing as well, and obviously a thorough history.
Absolutely. And so within the different causes of hypo, let's just focus on hypo for a second. Autoimmune is the most common. What are the other sort of insults that can lead to hypo?
So globally, iodine deficiency is the most common cause of hypothyroidism. That said, it's still low in Australian soil as well. So it's still something that is relevant to test for in any thyroid condition, because it's not just a problem in the developing world. So, but iodine deficiency is certainly the most common in terms of globally. In terms of general causes of Hashimoto's, the broad categories that we can use: stress is a big one. Diet, gut dysbiosis, and gut infections, and environmental toxins. So I would say they're your big broad categories in terms of what's underlying Hashimoto's, and indeed many autoimmune conditions. And as we know, autoimmune conditions generally are on the rise, and Hashimoto's is definitely increasing as well. Again, is that increased incidence, increased rates of it being picked up? Probably both. More recently, it's also been shown that COVID and even COVID infection as well as the vaccine can contribute to thyroiditis as well. And one of the reasons for that is that the thyroid gland is rich in these ACE receptors, which the spike protein of COVID can attack as well. So that's also something to bear in mind, especially given the current situation with COVID.
And with those constellation of symptoms that you just described for hypothyroidism earlier, so vague, right? So you've got your gastro symptoms, you've got mental health symptoms, you've got weight symptoms, all these different things. And they could, not all of them happen all together. So you can imagine the journey of a patient, or maybe even someone listening to this, bouncing from clinic to clinic, seeing different specialists, in their own silos, and not really thinking about the broader picture. So, as a GP, somebody coming into the office and saying, I've got these symptoms, you're thinking of hypothyroidism that you're going to test for, but I guess you're also going to be thinking about your differential. And so what are the other things that people should be thinking about, as well as hypothyroidism, when they might be suffering with these symptoms?
Everything links in with everything. So with the thyroid, we've got to think about the adrenals, we've got to think about the gut, we've got to think about the hormone levels, the estrogen progesterone ratios as well. There's been some interesting research a few years ago around anxiety and depression, such that they suggested that if someone has anxiety and depression, we should be screening for thyroid conditions and vice versa. So, and in terms of gut symptoms, like I said, constipation can be one of the only sort of main symptoms that someone may present with. And again, it can be easy to forget about thyroid, and people just hone in on the gut side of things. Other autoimmune conditions. So even though it's said that the thyroid gland is quite sensitive, and if there's going to be an autoimmune condition, that's often one of the first things to be affected, it's also important to look at other autoimmune conditions as well. So there is a link between, for example, Hashimoto's and celiac disease. So again, if someone has one, they're more likely to have another as well. going back to, obviously, stress is one of the main underlying factors when it comes to autoimmunity, and certainly Hashimoto's. Obviously, the adrenal glands can get affected, so people just have that low energy. And I think another important point to bring up is how we take it for granted. We're all stressed, and it's almost like it's just part of life and it's normal. And in the same way that, for example, women might have heavy or painful periods and it's just seen as normal, but it's not normal. So there's a lot of things that we've normalized around stress and period problems and even gut symptoms that we've almost just become to accept that as the norm, but it's not the norm. So yes, it's important to look at all the systems and, take that thorough history and comprehensive blood test to evaluate all the different symptoms as well, not just thyroid hormones.
Yeah. We're going to go into the differences between a sort of conventional approach and a sort of wider systems-based approach in a second. You've mentioned a number of times now that it's largely female patients that you're seeing with hypothyroidism. Are there certain times in life where you see an increased spike of hypothyroidism or thyroid health problems that people should be looking out for as well?
Sure. So I would say most presentations seem to occur between the 30s and 50s. There can be a shift around the menopause, and there can also be a shift in the immune system after pregnancy. So Hashimoto's or a thyroiditis can occur after pregnancy, and it's often can be misdiagnosed as just baby blues. So I think that's really important to consider as well, because there's just that shift in the immune system. And certainly around menopause as well, again, just that complex interplay of all the hormones, that can have an impact as well. Many other factors involved there as well. For example, we know that with menopause, you can get bone loss and osteoporosis. And as we know, that's one of the areas that we store toxins like heavy metals. So they can get released into the system, and then that can also then further aggravate the thyroid gland and other systems as well. So yeah, those areas. But what's interesting is that I'm starting to see younger and younger people with autoimmunities as well, even teenagers, which is quite disturbing. And I think, again, it's not so much, as we know, our genetics that has changed, that's the environmental toxins. We never used to see girls in their teenage years with Hashimoto's. So yeah, that's a complex interplay of factors, including obviously stress, toxins, etc.
Yeah, well, I definitely want to touch on the propensity of bone loss post-menopausal and the potential link between environmental toxins and the thyroid. That's a really interesting idea. I don't think I've looked into that too much. So I think we've given like a rich idea of the thyroid, what it does, the different types of thyroid health issues, the most common ones, the type of person that would have thyroid issues, and the other sort of differentials that we're thinking about. Let's talk a bit about how somebody would be diagnosed in a typical general practice setting, or maybe even secondary care setting, the bloods that they would have and the treatments, and then we can go into sort of, okay, that's great as a baseline, but like what's missing? So how would a typical patient that, let's say it was Dr. Amy before, you were educated on this wide, rich variety of different, content that you consumed and read and all that kind of stuff. What would Dr. Amy do, prior to all this stuff?
So we would do the TSH, which is a thyroid stimulating hormone. So that's the standard test in any country, actually. So that's the hormone that is made from the pituitary gland, which then basically stimulates the thyroid gland to make the thyroid hormones, mainly T4, which is thyroxine, which some listeners may be familiar that that's the medication that's given as well. So TSH is the test that's done. And certainly here, the Medicare ruling is that if the TSH is normal, there is no justification to do the T3 and the T4 levels. and nor the thyroid antibodies.
Ah, okay.
And that's also the case, in many other countries as well.
Yeah. Mm-hmm.
So, previously I would have done the TSH, done the thyroid test, and there's no red stars. I was like, yeah, let's die. There's nothing wrong with you. So,
Okay.
because when you're in that busy setting, looking at all the results, you're just looking for the ones that are marked abnormal. So, it wouldn't get picked up if it was in the range. So,
Mm-hmm.
generally speaking, when it comes to sort of primary hypothyroidism, the higher the TSH, that's implying the more underactive the thyroid gland is. So generally,
Mm-hmm.
when it comes out of that range, so let's just say the range went up to, say, 3 or 4. It can vary in different countries and different labs even. Once it comes out of that range, let's just say it's 5, then it will get flagged as abnormal. And then it's like, oh, there's underactive thyroid. So
Let's
it's
just,
higher.
sorry,
Sorry.
I just want to, just from the listener, because I know it's implicit in the name to us, like thyroid stimulating hormone, but I just want to underline that point, exactly how that hormone released from the pituitary interacts with the thyroid gland. So just take us through that little bit one more time, and then we can talk about why you would do the other tests as well.
Yeah. So there's a negative feedback mechanism. So there's a like a balance between the thyroid stimulating hormone and the thyroid hormones. So the TSH stimulates the sort of gets secreted from the pituitary gland, and then stimulates the thyroid cells to make thyroxine, which is T4. So that's the main hormone that's made. When the T4 or thyroxine level reaches an appropriate level, then there's a negative feedback back to the brain saying, okay, we don't need any more TSH here. So there's this constant sort of feedback and talk between all the different glands just to get the right levels of everything.
Yeah.
So thyroxine itself, T4, is as I said, is the main hormone that's produced from the thyroid cells. However, it's not the most active. It then has to get converted to T3, which is the most metabolically active hormone. The interesting part is that most of that T4 to T3 conversion does not happen in the thyroid gland. It actually happens outside in the peripheral tissues, such as the liver and kidney and heart, and just other tissues. So hence the importance of the whole body and not just the thyroid glands when we're discussing thyroid health.
So within, you got T4, it's out in the system, it gets converted to T3. How is that T4 uptaken by the liver cells, the muscle cells, the gut cells? Like in what form is it taken in? Is it literally T4 and then there's like a T4 receptor on the cells of these different parts of the body, or is it within the surface, or just talk us through that? I know it's a bit geeky. We just dive into that and then we can dive right back out.
So T4 is produced, and that is then converted to T3, which is the most active hormone. But it is important to remember that, yes, even though T3 is the most metabolically active, about 4 or 5 times as much as T4, both hormones are important. So even the thyroxine, the T4 itself, has a direct impact at the cellular level, or the to for example, in the gut, to cause intestinal motility, for example. T3 also, there's receptors at the cell surface and also mitochondria as well. So, and that is involved in upregulating energy, neurotransmitters, and so forth as well, and improving and increasing mitochondrial numbers and function as well. So both have their independent functions as well. Often we can get caught up in only T3 is important, but both are important at the cellular level for sure.
Yeah, I think that's a really important point. That because I think in a lot of people's heads, it's like, oh yeah, T4 is converted to T3, so we're just going to focus on T3. Whereas I think just to underline that point, T4 is important. It's not like a junk hormone molecule in the pathway of everything else. It's it is important. So yeah.
So, and as I said, the other key fact of note is that most of that conversion happens via these enzymes called deiodinases, which are located
Mm-hmm.
in the periphery. Not, so most of that conversion is happening outside the thyroid gland. Um, and again, as with any enzyme, there can be genetic defects, so that can also be a reason why people don't convert as well from T4 to T3, and why for some people thyroxine isn't enough, and they do need extra T3 given as well.
Mm-hmm. Mm-hmm.
Broadly speaking, in terms of the factors needed for that T4 to T3 conversion, I mean, the deiodinases require selenium. It's a selenium-dependent enzyme. But generally for thyroid function, we need selenium, magnesium, iron, zinc, B vitamins, vitamin C, vitamin D. And on the other hand, the things that can stop that conversion happening and the production of thyroid hormones, stress, as we said, is a big one. Toxins like other halogens like fluoride and chlorine, gut infections, plastics, heavy metals like mercury, which can actually concentrate in the brain as well and affect the TSH secretion. So if we have a situation where we don't have enough nutrients like zinc, selenium, iodine, etc., or we have too much of the factors that are impeding that conversion, such as stress and toxins and gut infections, then the body or the brain, in perceiving stress, says, "Whoa, there's stress here. We need to slow things down." So what then happens is that T4 starts to get shunted towards making another hormone called reverse T3.
Mm.
Reverse T3 is the mirror image of T3. It's the isomer, but it's inactive, and it's actually a hibernational signal in mammals. So again, I personally didn't have an appreciation of that in my old Dr. Amy days.
Uh-huh.
That just these are just things I've learned, as I've done this further training. So the body is trying to actually do the right thing because it's perceiving stress, whether that's nutritional deficiency or emotional stress or toxins, and saying we don't want to waste away here, because the thyroid gland is involved in metabolism, etc. And so it's trying to do the right thing. It's a survival mechanism to say, well, we've got to slow things down here. And so that T4 to reverse T3 shunting happens, so there's less T3. And then
Mm-hmm.
obviously we can then start to manifest those symptoms of hypothyroidism like fatigue, weight, which are annoying, but it's the body trying to do the right thing. So giving medication, yes, can help, but we need to see what's going on, because if something has come out of balance, let's try and bring it back into balance.
Absolutely. I just want to stop there actually, because I think this is a really good point to summarize everything you said, because the one thing that I'm getting away from this description of the different pathways is that depending on the individual, their threshold for disease or symptoms is going to be completely different. So first you have your thyroid hormone, the lovely shield in your neck, your thyroid gland rather, that puts into the bloodstream these hormones that keep everything fine and dandy. So you've got a well-functioning gut system, you've got a well-functioning metabolic system, everything, your temperature control, your thermostat, everything is working normally. This requires the conversion of T4 to T3. And depending on genetics, so the conversion of that T4 to T3 might be different. Depending on other stressors, including the lack of nutrients or the presence of environmental toxins or stress, that can dampen down that conversion to T3. And this can manifest in symptoms. The other thing, which again was new to me a few years ago, is when that conversion is dampened, you get this reverse T3, this sort of parallel conversion pathway that actually stimulates being like a bear, going into hibernation mode, where you just want to shut down. It's almost like, you have a flu and your body is telling you, you need to stay in bed. You're not going to go to work today. And you just literally can't get out of bed. You barely can have some broth and stuff. So this is giving like a real lovely picture, because everyone has different exposures to these stressors that can limit that conversion pathway, and they also have different genetics as well. So depending on which environment you find yourself in, you can manifest these symptoms, or people in this exactly same environment can, be stress-free and not have any issues with their thyroid. Is that sort of like an overarching picture of what you've just described?
Absolutely. Symptoms are messengers. So the body is, it's on your side. It is trying to do the right thing, for sure. And we have to be intuitive and listen to our bodies.
Yeah. Okay. So within mainstream, I hate the word mainstream. I've got to think of like a different word. That's why I always look to myself. I'm like, oh, Dr. Rupi, or like, oh, Dr. Amy. Someone would have come in if they've got like high TSH. We'll do some extra tests and say, okay, we'll top you up with a bit of thyroxine. What is that? What is that levothyroxine that we tend to be giving? It's a standard practice in the NHS. I'm not too sure if it's different in Australia anymore, but what else would you do within the sort of like conventional setting?
That would be the main treatment. So if the TSH is raised, then either it's monitoring or it's medication, depending on the extent. So and again, that can depend on the practitioner. Interestingly, the RSCGP guidelines allow a TSH up to 10.
Oh.
So hyperthyroidism will get recognized when the TSH
just for the
is
context
out of
for
that
the
range.
listener, what's the range that the Royal College suggests is normal for TSH?
Up to 10. Up to 10. Whereas from a functional medicine point of view, the optimal TSH is 0.5 to around 2.5, generally speaking. Generally speaking. And most lab ranges would go up to 3 or 4. So even recently, I saw someone who'd come in with symptoms, nothing's been diagnosed, and looked back at some previous results that she'd had done. Her TSH was 7, and nothing was said by her GP. So it's basically either monitoring or a medication will be offered, and that's T4. And that's a synthetic medication, which, it's given on the presumption that, yes, some of that will also convert to T3. The general ratios of T4 to T3 in the body is around 4 to 1 anyway. So it's made on that assumption, but as we know, not everyone converts to T3. So we may have a situation where the TSH is in the normal range. It's not high. It's not been marked as abnormal, but people can still have hyperthyroid symptoms because most commonly stress is actually reducing the TSH. Cortisol has the effect of not just reducing that conversion of T4 to T3, but also actually suppressing the TSH as well, as can sleep deprivation or illness or starvation and very low calorie diet. So that's why it's important to look at the whole picture and not just that TSH.
I just want to underline that point. I think that's a really important point there, because it goes towards this sort of concept of cortisol steal. So maybe we could just back up a bit and just talk a bit about what we mean by cortisol, because I think, again, it's one of these terms like, measure your cortisol, your cortisol's high, whatever. What does that actually mean? Because it's very high up the sort of food chain of hormones, and it can have that sort of effect downstream, particularly on thyroid hormones. So let's start with cortisol, where it's released, and how that impacts these other pathways that we've already described.
So cortisol is like the stress hormone that's made in the adrenal glands, but in the hypothalamus, which part of the brain, that makes a hormone called corticotropin releasing hormone, which then stimulates the pituitary gland to make ACTH, adrenocorticotropic hormone, and then that stimulates the adrenal glands to make cortisol. So that's a feedback loop in itself. So often known as the HPA axis, or the hypothalamus pituitary adrenal axis. And then we also have the hypothalamus pituitary thyroid axis. Cortisol has many functions, and CRH, ACTH, they can also suppress TSH as well. So if we're in a stress situation, again, the body trying to do the right thing, it wants to slow things down. The effects actually start upstream, where you get a reduced TSH, and then hence the thyroid hormones as well. And obviously cortisol's effects on increasing reverse T3 by reducing that conversion of T4 to T3.
Yeah. So this is where you have an environment where your TSH might be in the normal range or the high normal range, but there is still an issue going on because you haven't, perhaps through even, I'm sort of more leaning towards like taking a really thorough history. You don't have to do all these extra functional tests in my view.
Yeah.
You can simply ask the questions about stress, and that can potentially explain normal TSH results with the presence of a thyroid condition.
Yes, yeah, absolutely. And as you said, we need that full history, and obviously appropriate examination as well, and also to look at the actual results and not just look at what's in range. So to consider what is the TSH, but what are the T4 and T3 levels? I mean, obviously that's further tests that that can be done later, and I routinely would ask for all those, especially if there are thyroid symptoms. So even then, when we look at the T4 and T3, it's not just in a range, but is it optimal? So, and obviously the thyroid antibodies, I would do, especially if I'm suspecting Hashimoto. So we're justified to do those blood tests if there are the clinical symptoms, and that's where Medicare would support further testing if we have clinical relevance.
Yeah, Medicare
course,
being the sort of equivalent of the NHS, but in Australia.
Yes, that's right. Yeah, yeah. And also, obviously, when we're doing the blood test, we'll do a comprehensive set of blood tests. And that can include the adrenal hormones. So it's not the most accurate in the blood test, but they can be done to give us an idea. And at least if they're very high or very low, that tells us there's some obviously adrenal function going on here as well. There's also another adrenal hormone called DHEA that we measure as well, and that also tells us a little bit about adrenal function as well. So a comprehensive set of blood tests looking at the whole thyroid panel, but also adrenals, nutrients, sex hormones, lipid profiles, because again, thyroid hormones are needed for cholesterol metabolism. So often people may have high cholesterol. And going back to what we were saying earlier, where people can be seen in different departments and their diagnosis hasn't been made. So someone might have fertility issues and be, go to a specialist. They might have high cholesterol or palpitations and be sent to a cardiologist. Gut issues and constipation and be sent to a gastroenterologist. Anxiety, depression, psychologist or psychiatrist. So comprehensive history exam, appropriate testing, and taking it from there.
I think these are some really important points here. That's why I want to stay on this section for a little while, because we've talked about like old Dr. Rupi or old Dr. Amy, those sort of standard blood panels that we do, send the patient away, like there's nothing wrong with you, your bloods are normal, or okay, we'll do a few extra tests, but if the antibodies are negative or whatever, then we won't do much else. What you rattled off some extra blood tests that you do. Someone comes to see you and you're suspecting low thyroid, a low thyroid condition. What kind of things do you want to make sure that you've checked before you start instigating any treatment, or you formulate a diagnosis of not just low thyroid, but the root cause of said low thyroid condition?
Yeah. So in terms of the thyroid panel, it would be the TSH, T3, T4, and thyroid antibodies. I also run adrenal hormones, so cortisol and DHEA. Standard tests such as a full blood count, make sure they're not anemic, urea and electrolytes, liver function tests, because that can give us some markers around inflammation, for example, especially some of those liver markers, inflammatory markers like CRP, ESR, just to assess the state of any inflammation in the body. Depending on other symptoms, I may also run other autoimmune tests. So, for example, many patients with Hashimoto's, even though they may not have celiac disease, have the celiac gene. So that's one of the genetic predispositions to developing anything autoimmune, not just celiac disease. So I find that most of my patients with Hashimoto's do have the gene, even though they may not have celiac disease, but obviously they're at increased risk for that. There may be other auto antibodies I may run, again, depending on the symptoms, but ANA, which is anti-nuclear antibody, if that's positive, then we can do more thorough testing, which can indicate whether they might have connective tissue disease or lupus, for example. Nutrients like iron, B12, plasma zinc, serum copper, I test for as well.
How accurate are the bloods that look for specific mineral or trace minerals in blood? Because my understanding is, depending on the nutrient, you know, a serum level doesn't tell you much, and you're really looking for an intracellular level, but there aren't many tests that can give you that sort of that can delineate between the two, which is quite important.
Sure. So it's a guide. It's more to assess if there's a significant deficiency. So, for example, magnesium is a difficult one to test for. We can test for red blood cell magnesium, but it has to be pretty low for it to show up. But certainly, I find it can help in terms of, for example, plasma zinc and serum copper, because that ratio is important. Like we know that low zinc to high copper, there can be a correlation with anxiety, for example, and high copper can also deplete other minerals as well. So it's a guide, but there are also other functional tests that can be done. But because the tests that can potentially be done on Medicare, you know, it can be done as screening, and also depending on other symptoms, like if there's hair loss, for example, then it will be more relevant to do some of those bloods.
Yeah. Okay. and okay, so you got these bloods. Let's say you got a perfect patient. They're just like, give me all the tests. I want all the tests. I want to know. I've got an analytical mind. You've done all these. What are some of the? We've already talked a little about what could predispose or preempt the hypothyroid condition, the low thyroid condition. What are some of the things that you're seeing that you're like, I found it, and then I'm going to fix that? What are the main sort of root causes that you're seeing these days?
Yeah, so certainly the blood tests are important in terms of, I guess it's never one thing. It's always a combination of many factors. Stress and how that manifests in terms of the level of the cortisol DHA is certainly a factor. There are often nutrient deficiencies, often iron and B12. So, you know, even in people who, for example, they may not be vegan or vegetarian, but they can still have low iron. And often it's microscopic loss through the gut wall because of a leaky gut. And that obviously is one of the key things that we then need to address later is the gut and the diet. As we know, most of the immune system is in the gut. So if there's an autoimmune condition going on, it follows that is one of the main things that we should be looking at later on. Sex hormones. So, for example, there might be an estrogen dominance, which again is very common in women. And generally what that means is there should be a specific ratio of estrogen to progesterone. So what's common in women these days is that the estrogen is relatively higher to progesterone. And that can manifest as PMS symptoms, fibroids, endometriosis, ovarian cysts, breast cysts, for example. So that also impacts thyroid function because high estrogen levels increase something called TBG, which is thyroid binding globulin. As a result, that means there's less free thyroid hormones circulating in the blood. So basically, high estrogen generally does correlate to low thyroid function as well. So it is an interplay between all these different glands. Nutrient deficiency I do find are quite common. B12 deficiency can occur, and that's, again, that could be absorption often as well. So again, even in people who are not necessarily vegan, people may have Helicobacter pylori infection, and that's also been shown to be one of the triggers in Hashimoto's as one of the potential infections that can contribute towards triggering Hashimoto's. And of course, there's autoimmune conditions involving the stomach, like pernicious anemia, but we just can't absorb that as well. So they may also have that as a coexisting autoimmune condition as well.
I just want to dive into iron and B12 because I think as a vegetarian yourself, I think this is quite an important area because there is a misconception that, if you've got red meat in your diet or you eat, a selection of animal products, you're going to be fine from a B12 and iron point of view. But you mentioned leaky gut there or intestinal, what's the official name? I forget it now. It's not
Hyperpermeability.
hypertrophy. Hyperpermeability, that's it. Sorry, my
Hyperpermeability.
brain's not functioning this morning. Yeah. Intestinal hyperpermeability.
Yeah.
How does that manifest in someone who is eating or consuming enough B12 in their diet, presumably?
So, in terms of the main factors, it could be, again, there's various factors. There's something called the autoimmune triad. So there's three factors there. One is the celiac gene or genetic predisposition to developing autoimmunity. Then there's intestinal permeability, and then there's triggers. So some of the things that can contribute towards so-called leaky gut, gluten, like the gliadin in wheat especially, has been shown to increase intestinal permeability. Infections is a big one. So bacteria, even certain parasites, have been shown to also contribute towards leaky gut as well. So what we mean by leaky gut is it's actually at the microscopic level, this description. So essentially speaking, if we have adjacent cells, there's a tiny little gap between those two cells to allow nutrients to get absorbed back into the bloodstream and toxins to get excreted. But what can happen is if that barrier is damaged because of, say, certain foods like gluten, infections, toxins, that gap can widen. And then what that potentially can mean is that nutrients can get lost when they should be getting reabsorbed back into the bloodstream. And it also means that toxins can enter the bloodstream as well.
The hyperpermeability element is very much in the name. It's hyper because the intestinal permeability is a normal phenomenon. Whenever we eat anything, there are going to be gaps in those tight junctions of our digestive cells all along the digestive tract, largely in the large intestine, and that's to facilitate the movement of nutrients into the bloodstream that we need. The excess of that process, which allows things that should be maintained in the gut and not pass through the gut wall into the bloodstream, that's when you can get into problems. And I believe the gliadin proteins for certain people and people with particular allergies to certain types of food, this is what can manifest in this issue. Have I got that right?
Yeah, and it is a combination of factors. I wouldn't say there's ever just one thing. And when it comes to that diagnosis being made, it's sometimes the straw that broke the camel's back. If we then look back at the history in their life, there's been a lot of insults, whether it's emotional stress or many factors, diet related. So yeah, it's a process. It doesn't just happen, but there's often things that have been happening for a while, and then it can just be a life event that can just sort of trigger someone.
Okay, and so let's dive out a bit into. I think that the autoimmune triad was very important. The genetic predisposition, the permeability of the gut, and particular triggers as well. Actually, another sidebar before we carry on, because I noticed you said infections, and the thing that most people think of are things like H. pylori, but there are other infections, aren't there? There's Epstein-Barr virus. There are infections that we might have had as kids and just completely forgotten about, but these can manifest quite a lot later on in life, right?
Absolutely. So gut dysbiosis, for example, which describes that imbalance between the good and the bad bacteria. So, for example, there could be certain bacteria that can act as a trigger as well, and parasites. And one of the things that we see in the gut microbiome test is an overgrowth of, for example, streptococcus. So strep, as we know, as a bacteria, is commonly, we've all been exposed to it in some form in terms of tonsillitis, strep throat, chest, ear, sinus infections. And what we know about streptococcus, which is quite interesting, is that it can persist in the system. We don't always get rid of it. And there has been research where, because of the various toxins it produces, including lactic acid, it can actually contribute towards chronic fatigue syndrome, fibromyalgia. It can also be that trigger through molecular mimicry in autoimmunity as well. So that's certainly one of the common things that we tend to find as well. And again, this is digressing a little bit, but the acronym PANDAS, which is Pediatric Autoimmune Neuropsychiatric Conditions Associated with Streptococcus, it's a well-known thing, especially in the States, not so much perhaps in the UK or Australia, but that can also then persist into adulthood if that strep is still there. I just thought of Dr. Alessio Fasano's quote. He's the obviously the gastroenterologist who's done a lot of research into zonulin and leaky gut, and he says, the gut is not like Las Vegas, so what happens in the gut does not stay in the gut.
Yeah, exactly. Okay, so when it comes to managing hypothyroidism, right? So someone comes into your clinic, you've done the tests, they've got low levels of the thyroid hormones in their blood. How do you manage the acute phase? Like someone needs a fix right now, versus some of the other things that might take a little bit of work. So talk us through your structure of how you see a patient comes in. You're going to treat them. You're going to improve the management of this condition that is lifelong as best as possible. Talk us through that process.
Yeah. So in terms of medications, again, it depends on the extent of the symptoms, and if the levels are quite low, they're quite symptomatic, then we can certainly start treatment. And I would have that discussion, on that individual basis of whether we start thyroxine, T3, or a combination. Obviously, it's not the first line, but if that's needed, depending on the severity of the symptoms, then it's totally justifiable. But my general framework is to look at all the foundations, which starts with lifestyle and environmental factors. Now, obviously, this is a longer term approach. But I think that's important for the long term. But certainly, medications in the short term at least can help, with the knowledge that later on we may be able to reduce that medication and maybe even stop it altogether, depending on the actual scenario. So yes, thyroxine may be necessary if we have done their reverse T3 and they've got a low T3. A T3 in addition may also be justifiable as well, and that's again also a common scenario where we see people come in who are already on thyroxine, but they're still not feeling great, and that further testing reveals this low T3 and high RT3, and they start to feel much better on T3. If that's not sufficient, then there is another treatment that can be used called thyroid extract, which was interestingly the original treatment before the pharmaceutical companies started manufacturing thyroxine. And this is just very briefly, it's porcine or bovine derived glandular extract from the thyroid, which is made by compounding pharmacies. So I know there's not that many in the UK, but there's certainly a lot of compounding pharmacies in Australia, and it's quite easy to get. And the good thing about that is that it's naturally got T4 and T3 because it's from the thyroid gland, and it's got other thyroid hormones. There's T1, T2. It's got other nutrients like selenium, for example, as well. So that can suit some people. And when T4, even with the addition of T3, isn't enough to control symptoms, I often find that once they're put on thyroid extract, it does help. So again, that's also very individual, and some people may not want to take it. That's anything that's animal derived, but there's certainly some good research on it. And T3 is not commonly prescribed by practitioners. So yes, T3 is available as a medication that is used by endocrinologists, but it's a synthetic version. We can also have T3 compounded in different doses, but it's not your general one that most GPs would prescribe. That's generally in the realms of integrative practitioners.
I just want to clarify, levothyroxine what are we referring to? And when we say T3, is there another particular word that people use?
Yeah. So levothyroxine is thyroxine, or T4 is what we commonly call it. T3 is liothyronine, which is the technical term, but yeah, it's T3. So essentially, as we know, that's a tyrosine backbone with 4 iodine molecules. That's T4. T3 is the tyrosine amino acid backbone with 3 iodine molecules. Um, so, and as we know, the thyroxine is the general treatment that any GP would be familiar with. T3, at least here, I don't know about the UK, but here some endocrinologists do prescribe a branded version called tetroxine, which is a 20 microgram dose. But thyroid extract is not prescribed conventionally. It's only prescribed by integrative and functional medicine doctors.
Yeah. I haven't actually heard of a thyroid extract before. And I guess what would be the potential downfalls of having a thyroid extract? Is it because they're not regulated like most pharmaceuticals? You could get differing doses depending on which compounding pharmacy you go to. Yeah.
So it also, because it's a natural product, it has iodine in it, and some people can be, especially with Hashimoto's, can be quite sensitive to iodine.
Yeah.
So you can actually flare. No, iodine is it is very, very individual. Yes, we need it, but too much can actually worsen thyroid function. And yeah, in terms of, it depends on the compounding pharmacy. So I use specific ones which we know that they're certified to the extent as that what we get is what is that actual dose. But yes, there can be that variation because a lot of some compounding happens at the back of retail pharmacies. It's not as well regulated in terms of the conditions and everything. So it does depend which compounding pharmacy you use.
Yeah. Okay, that's a really good point to make. So let's talk about. So we've got the medications. You've got your selection of different drugs, of which we've just clarified there. In terms of those foundations, how do you go through those in a stepwise fashion?
Yeah. So main categories, obviously stress, sleep, nutrition, movement, environmental toxins. So they're the sort of things I'm going through in my head.
Mm-hmm.
There may be many things that need changing or improving in someone, and I like to do that as an overview. But we also have to, it's personalized medicine, and we have to take it one step at a time, depending on the individual. Not everyone can sort of radically change their diet and change their life in a matter of days, but it's important to manage stress. And as we know, it's something that we take for granted, but it's important to take steps to mitigate some of that day-to-day stress, even if it's saying, okay, well, let's start a short meditation practice once a day, or do something like yoga nidra, which is like a lying down progressive muscle relaxation meditation, which has a lot of great research around it, helping to improve sleep as well and balancing the autonomic nervous system. So strategies around stress as well, stress management. As in anything, it's about meeting the person where they are, and some people are not open to doing meditation. It's finding something that they're comfortable with. Sleep is also really important. So again, I think this is something that doesn't get talked enough about. We take it for granted, and we think we'll be okay with a few hours of sleep. But as we know, there's so much evidence on why sleep is important, and sleep itself has been shown to affect thyroid function. Not surprisingly, it will suppress the TSH as well. So really important to talk around the sleep hygiene, even if it's saying, right, let's go to bed at 10 or 11 rather than 1 or 2. Just little strategies around that as well. In terms of diet, again, there are specific diets that have been shown to help in Hashimoto's, but long term we want obviously a healthy, whole food, plant-based diet. So I'll talk through the principles of that. But in terms of Hashimoto's, gluten and dairy-free diets have been shown to reduce the antibodies. They do help to reduce inflammation. a lot of the studies that have been done over like a 6-month period. So it's important to tell someone this is not just a few weeks worth. You might need to do it for longer. It doesn't necessarily have to be forever, but at least initially, while we're trying to improve things and improve the gut function and reduce leaky gut, let's just do the best we can. So the gluten dairy free diet can is one of the main things that I would start with. There is also another diet called the autoimmune protocol, which is commonly used by many practitioners. That's much more strict. And I personally don't start this straight away because it can be quite restrictive and also quite difficult to do if you are vegetarian. And that, as we know, that cuts out grains, legumes, nightshade vegetables, like so many things. But the studies are positive in terms of they have been shown to reduce inflammatory markers. In one study, it didn't actually reduce the thyroid antibodies, but the study was only done over a short period of time. So again, changes can take a while for them to show up. But anecdotally, clinically, as well as from what the research is showing, they're the sort of diets that can be helpful. But it also depends on what else is going on with the patient. So there may be IBS and a low FODMAP diet could be trialed. There may be small intestinal bacterial overgrowth, and we might need to think about a SIBO diet. We might need to take into consideration the fact that someone's vegetarian or vegan as well. So potentially a wide variety of diets that can be used. I wouldn't say there's one Hashimoto's diet or anything like that. In terms of movement, too much or too little movement is pro-inflammatory. So sitting is the new smoking, as they say. We know from studies that prolonged sitting, can increase inflammation as well. So, simple strategies like, if someone's, sitting down all day, just to get up every hour or so, just have a little bit of a stretch and walk around for a bit. But also too much exercise has also been shown to be pro-inflammatory and also even contribute towards leaky gut. So they've done studies on long distance running and marathon training where that can affect sort of the gut function as well as thyroid function as well. So we need the right amount of movement, and obviously in many situations people are just tired, they don't want to do anything, but there again it's just a case of just meeting them where we're at, and even if just a little walk, a little bit of stretching, a bit of tai chi, qigong, restorative yoga, often that's the sort of thing that we need to think about, not Bikram yoga. So
yeah, totally. I just wanted to just touch on the nutrition element. I think it's really. I've had a family member actually recently go on an autoimmune protocol diet as a result of a hypothyroid diagnosis. And I think when you do these things in isolation, particularly, people want to do something that they feel is more tangible than just optimizing their sleep or reducing their stress or doing some breathing exercises. And so they go all in on quite a restrictive diet. And like you said, it's bloody hard to do an autoimmune protocol diet because you're literally removing a lot of very, very healthy ingredients, and you end up just having things like soup, because there's literally nothing else to eat. So part of me is like, is it the ingredients? Is it the fact that you're on a low calorie diet? Is it the fact that, you're not going to have any permeability because you're basically not eating anything? There's a whole bunch of like holes that people can fall in. So I think doing something very basic, like removing the crap from your diet as a first point of call, that a lot of people who perhaps see you have already done. So maybe that's why they need to go down let's trial a GF and a DF diet. But removing a lot of the elements that are pervasive in our food landscape, emulsifiers, additives, high amounts of sugar and salt, that toxic combination could be enough for a lot of people as a first point before they entertain more sort of extreme measures.
Yeah, absolutely. And I think it's always important to get that balance and always discussing what the components of like a whole food plant-based diet are, and for them to as you say, just try to eliminate or at least reduce some of the pro-inflammatory foods and drinks that they're having as well. Whether it be alcohol or excessive caffeine, or having gluten every day, takeaways. Even takeaways, even though they might be Thai or Indian, they could be seen to be sometimes potentially healthy. They're not, because of the oils they've been cooked in, etc. So yeah, I think that all those basic principles are really important before embarking on anything. But yeah, as you say, often by the time people come and see integrative practitioners, people have already been down this rabbit hole of different diets. And um, I do believe in a balance for sure. And you often find people who get so restrictive, and it just starts to affect their mental health because they can't go out, they
Yeah.
can't go. So it is that balance. And I remember a patient who had colitis, and on a strict diet, went to Italy, had a holiday, was eating pizza, pasta, everything, and they were fine. So
Yeah.
so many
Yeah.
factors. And again, we can digress into the wheat in Italy is different from the wheat here. It's all sorts of things like that. But I do believe in balance, totally,
Yeah. I,
for
I,
the
I
long
think
term.
there's a mindset element as well. I've got a friend of mine, one of my closest friends, who's definitely lactose intolerant, and he went to America. He went to like it was like Disneyland or something like that, and it's like favorite place in the world. Stress free, loving life. Had all the cheese he wanted, didn't have any symptoms. He was like, it can't be the quality of the dairy that I was eating. I was eating like the worst type of dairy. His mindset, it was his mind. Like when he's back
Yeah,
here in the UK, like he's running a company, super stressed and all that kind of stuff. So I think there's a rich
yeah,
interplay between our perception and our gut, as well as we know through the gut-brain axis. So I think that's really
yeah,
important. I want
yeah,
to touch on an uncomfortable truth about environmental toxins. We've talked to Professor Shanna Swan on the podcast before, and she really like made me worried about everything. And so, at the risk of painting a really bleak picture to the listener about the state of our environment, we should probably talk about toxins and the impact on thyroid
yeah,
health as well. How do you approach
yeah,
that subject with your patients?
yeah. So, as we know, chronic illness as well as autoimmunity is on the rise. A large part of that being because of environmental toxins, including heavy metals, plastics, parabens, things that are just found ubiquitously everywhere. Um, Awareness for one, so that I sort of give them resources around what they can do practically. So simple practical strategies may be, for example, especially for a woman, the moisturizers and makeup and cosmetics, to try and at least use natural products, because the parabens and phthalates, etc., found, and all the chemicals found in these products, are endocrine disruptors, not just for thyroid, but for insulin resistance, etc., as well. Um, so simple strategies like just converting it over to something that's more natural, and luckily there are so many more products like that available now, which are more environmentally friendly. Drinking water is important, like in terms of trying to get it filtered, because again that can have other halogens like chlorine and fluoride, which can compete with the iodine, and that can also worsen thyroid function as well. As well as obviously heavy metals, etc. So you know, filtering their water. Um, Again, there's many companies here that are available. It can be done quite inexpensively as well, and again, that's also another point. When we're talking to patients about strategies, we've got to be practical. It's everything
Mm,
can cost money. Um, so coffee cups, for example, like drink coffee out of a normal cup, because even the plastic lining of takeaway cups and the lids, that's plastic. So when you've got hot acidic coffee, that's leaching out the plastics as well. And to in terms of plastics overall, like BPA free isn't good enough, because we know even BPA free has other plastics that are just as bad, if not worse, than BPA as well. So yeah, awareness around all those different environmental factors as well, for sure.
yeah, yeah. Yeah, it's an absolute minefield. I think there are some simple things you can do. One of the things I've been taking to doing is just trying to get into my park as much as possible, and instead of and I do really strange things like, and I doubt it's having much of an effect. But if I'm going somewhere in London, I try and take the scenic route. So I try and look for parks along the way and try and go along those routes rather than going
Yeah.
alongside roads. And it's a stupid thing, and maybe it's the placebo effect or whatever. But I just feel like I'm filling my lungs with a slightly cleaner air. But I mean, yeah, this is pollution everywhere, so you can't really do much
Yeah.
apart from moving to the countryside, which I'm trying to convince my partner to do. Um, with regards to supplements, so
Yeah.
obviously you're going to be personalizing it according to whatever deficiencies you might be finding, whether it be
Yeah.
selenium, magnesium, etc., iron, B12 that we talked about earlier. Are there specific
Yeah.
herbal supplements that you think are particularly interesting from a research point of view or a personalized medicine point of view?
Yeah. So in terms of for the thyroid specifically, like for example, there's certain herbs like Nigella, hemidesmus, curcumin that have been shown to improve thyroid function. Aloe vera is an interesting
Ah,
one. There was actually a recent study where they found that aloe vera reduced thyroid antibodies as well. So you actually see, um, aloe vera, Nigella within supplements these days as well. Hemidesmus is another herb which has been shown to have immune modulatory effects as well. Curcumin, as you know, that's good for everything. There's nothing it's not good for. Because obviously inflammation is one of the key things, key factors that's happening within any of these patients. So that's good, obviously, for reducing inflammation, for liver, cognition, etc. So yes, a wide variety of herbs, often as part of formulations, that they're not having to use everything separately. So I'm quite mindful of how many supplements we use, because obviously I always say, look, the more we can do from lifestyle, the better, because we don't then need to use as much. And obviously to incorporate whatever herbs we can in the cooking. And so even obviously turmeric in the cooking, yeah, for example. Um, even teas like dandelion tea is great for the liver. So we don't always have to have specific supplements, because obviously too many supplements can be not just overwhelming, but can get expensive for people. So incorporate whatever great herbs and nutrients that obviously you can in the diet as well, for sure. Um,
yeah, like a herby, spicy diet that's full of color is basically
yes,
good for everything. Some
yeah,
discovery when
yeah,
chatting to all these
yeah.
people.
Yeah, and as we know, when it comes to the gut, it's and the gut microbiome, it's diversity and variety are the key words. We want a variety of different colored foods and veggies and fruit and everything, because that is what creates a diverse microbiome, which is then beneficial to our health. And again, studies have shown that there is a diminished and a changed gut profile in people with Hashimoto's as well. And interestingly, there's been research on how specific nutrients influence specific bacteria as well. So zinc, selenium,
Mm,
magnesium, they've all been shown to influence good bacteria as well. So,
yeah,
so lots of good, interesting research coming out.
really interesting. That's awesome. Amy, this has been great. I think we've really taken the listener on a journey of understanding their thyroid. Even if they don't have a thyroid problem, I think it's really important to understand the sort of how interconnected everything is and how you can't treat anything in isolation. You've really got to be thinking, casting that out wider when we think about certain elements and how this can interplay with the menopause, cardiovascular problems, off cholesterol ratios, weight, gut problems. Everything is really interconnected, and thyroid, I think, doesn't get as much attention as it should do, particularly as it affects a certain part of the population more so than others.
Yeah,
So this is great. I
yeah,
love your work. I love the book, and we're gonna do this again some other time when I'm next in Australia.
definitely. Have to catch up soon.